Good morning, everyone. Thank you for coming to this meeting. I know it's an extra one, and I do appreciate that. Some people do work, so thank you for taking the time to come today. So it is a reconvened Health and Adult Social Review and Scrutiny Committee from the 20th of February. Before we start the proceedings, I've got like a bit of a tinny here, am I? It sounds as if I'm like a bit of a Dalek or something. Sorry, it's me. Oh, okay. Okay. No, that's absolutely fine. Before we start these proceedings, may I bring to your attention to some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room, committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please, can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. Your mobile devices, please put to silent. So, item 1. Elliot, apologies.
Thank you, Chair. Apologies received from Councillor Ricketts and apologies received from Councillor Toohey. Councillor Rainsford is substituting as per the first meeting. Thank you.
So nothing from Councillor Finn?
Not that I'm aware of, Chair.
And we didn't have anything from him last time neither, did we? Right, okay, thank you. Item 2, declarations of interest. Got any declarations of interest from anybody? No. Okay. So we're going to go on.
Sorry.
Yep.
Checking there was one section that, that talks about community builders as part of support, so I declare an interest on
that. So now we're going to go to end of life, and it's over to you, Chris, and your team once again. So thank you all for coming today. I know it's a bit of a pain having to come back, but I think we just needed to give all of this justice, and we didn't want to rush from last time. So thank you.
Brilliant, thank you, Chair.
Yes, Will.
Sorry, I forgot to say I work for Plymouth Hospitals, Plymouth University Hospitals NHS Trust for previous bit. Sorry.
Thanks, Will.
Thank you, Chair. Okay, so thank you again for having us back for this second session. We've split out the pack, so many of the slides that you'll see were included within the original pack that came round. There are a couple of supplementary ones, and we've got some supplementary colleagues with us as well today who've come along and to talk in a little bit more detail around particularly some of the initiatives that are already underway with a community focus and some of the work that's taking place in Plymouth that we're really keen to share with you today. There's also some slides at the end that describe and kind of bring together actually the full body of the improvement work where we know we've got gaps, some of the certainly informed by some of the conversation that we had last time, and we'll just pick up a little bit at the end around some of our next steps, and we're keen to share that and help shape that as we move forwards. So the next slide, please. So this next slide is one, oh, can we get it? Sorry, technical challenge. But so the next slide is one that you'll have seen in the last pack, and this describes the different phases of end-of-life care. Just wanted to kind of reiterate that around, actually we spoke quite a bit last time, didn't we, around the individuals in the very last days and hours of care, and absolutely what we recognise in order to improve and address some of the challenges that we've got is that we need to move much more into that earlier stage, identifying people at an earlier point, having those conversations and making sure that the community wraparound support offers that we've got keep people out of hospital in order that we can support them in their preferred places too. And then next slide, please, Jane. And so this one as well, just a quote that was in the last pack and just makes the point around, absolutely the NHS has a key role around making sure that we've got support for individuals at end of life, but actually end of life is a social thing. There's a much bigger component to this than just the health component. And I hope what you'll hear today is some of the work that we're doing with partners, and partners are supporting us with, about how we shift some of that focus a bit. So I'm just going to hand over to Shane and Sharon now. We're going to talk a little bit about the 100-day challenge and the focus that we've had around end of life.
So in September 2023, we were challenged over 100 days to make a difference to patients who were being admitted to ED at end of life, but the focus was more on those patients who were coming from care homes across the city. So we had 10 care homes that were seen as the top admitters, and we went and spoke to those care homes to see what the issues were and what more support we could actually put in to help them with that.
Sorry. Yes, Angela?
Sorry, could I just seek clarification at this point? I thought there were some care homes that were deliberately for people nearer the end of life. People got transferred to them, so they'd be in a different category.
Yep.
So
people,
you'd expect people to be going from them. So I just wondered if you could clear that up for me.
so people who are in care homes may well die in a care home. However, these people, even though they were in maybe the last hours or the last days of life, were actually being then taken from the care home into the emergency department at UHP. And some of those people were actually dying there or dying en route in an ambulance. So what we were aiming for is to keep those people in their care homes in their preferred place of death, where it was that they actually wanted to die.
I'll let you do this, Angela, because I would have liked to have just heard the all of this before we ask questions. But go on, I'll let you.
It's just because I have been visiting care homes in order to see how they're performing and what their problems are. And one or two say, well, there's this other home where when they get very sick, we pass them on. So I just wondered if there were different categories, or maybe I'm just talking about nursing homes and that doesn't fall into that.
So,
Sorry, I just thought it would, when we say this conveying care home, this phrase, I just thought it'd be useful to have the clarification before we continue.
So people could be in a residential care home, but they could be in a nursing care home. So in a nursing care home, people would have 24-hour nursing care.
And it's worth saying, so in answer to your question, Angela, we don't commission any specific care homes specifically to deliver end-of-life support, because we recognise, as Sharon was describing, many residents within homes will enter an end-of-life stage. So our focus is very much about how we support all of those homes in order to be able to care for individuals. I think we'll talk later about some of the improvement work and some of the work that we want to do around looking at how we best support individuals whose choice is to enter a care home at end of life. But the current arrangements, whilst there might be some homes who choose to specialise in particular areas, there isn't a separate arrangement around those as such.
You'll get the chance to ask another question in a bit, Angela. Is that all right? Yeah.
Yeah, so we went into the care homes with a set of questions that we asked each of their care homes and got their feedback about how they felt about the support that was already available to them and what further support perhaps they would like or they felt would benefit their residents as they were approaching the end of life or even in the last 12 months of life, so anticipating somebody's death and putting plans in place. And then from that, we came away with some recommendations.
I think the other thing to just touch on as part of this piece of work is it was across organisations. So we had hospital representation, Live Well, Marie Curie. We had a really strong patient voice in terms of representation, St Luke's. So it was a real partnership approach to how we could look at what was going on in those homes and how we could potentially support them better moving forward around decision making and helping those patients, be looked after in their preferred place of care. So some of the recommendations that came out of the work we did is feeding into ongoing pieces of work now. So as we moved out of that 100-day challenge period, there are pieces of work that are moving forward because 100 days wasn't enough in order to take the work forward. So one of the recommendations is we look at what good looks like, and we share that with care homes across our area. So we know that some homes had some really clear standards around what they would expect to happen in their place of care, and other homes didn't have such a clear idea. So I think there very much is a piece of work around setting as to what good looks like, and sharing that with those care homes. The creation of an educational offer. So we know again that some care homes were really engaged with things like the St Luke's 6 Steps programme, and we know that other care homes have been engaging with other elements of end-of-life education as part of their own arrangements. But again, there isn't a necessary standard as to potentially what we would expect, and actually what we can offer as providers to those care homes. So there is a level platform in terms of understanding. In conjunction with commissioning, to agree a minimum standard of support and engagement with care homes in terms of primary care. So when we were talking to homes, there were again different arrangements with GPs that were supporting those homes. So some had very regular kind of weekly GP coverage coming in to see patients, and then other care homes had something that looked more remote. So I think there's an opportunity to work with commissioning around, what does good look like, and what's the kind of minimum expectation around what we would expect our colleagues to deliver. Revisit the immediate care offer, and I think that's something that very much sits with Chris and Jane around the immediate care kind of offer that exists, and that's around remote support and decision making for people who become unwell. And there was a bit of unsurety as to where that programme was going, and I think care homes were saying, what will this look like moving forward? Extend the administration and availability of IV antibiotics. We know that lots of our patients come in from care homes because they need antibiotics or fluids, and for some people at end of life, that may be the right thing to do. For other people, it's not the right thing to do. But actually, where it is indicated for quality of life or for something around easing, easing that passage of time, having that available more readily in care homes is something we need to look at, and we've got a subgroup working on that at the moment around improving the availability of that. End-of-life support line. So the group very much wanted to reflect back to the system as such, that having one telephone line for our professionals in care homes to be able to call would be really, really helpful. So actually, do we do 111? Is it 999? Is it immediate care? And I think there were lots of different options. And what our colleagues were saying in nursing homes and care homes was that having one point of reference would be really helpful to them, one telephone number. And family and patient kind of information leaflet. We know that each organisation has got resources around maybe what to expect at end of life and recognising dying, but it's quite kind of spread across, and there are multiple leaflets, and actually having one source of information would be really helpful in terms of being able to send a common message wherever people touch our services. So those were some of the recommendations and pieces of work that fall out of our work. One of the things that came out of the challenge, which was one of the greatest things, was a renewed sense of kind of team working, and I think that COVID created lots of issues and almost pushed us back a little bit. So lots of Teams calls, and we didn't necessarily see each other as much as we had. But this project really brought our organisations back together. And there's been some other pieces of work not related to the 100-day challenge as such that we've picked up with St Luke's and with Marie Curie, and the bit that sits outside that is bringing us back together. as a a system of like-minded people on on one problem. So that was a fantastic outcome for us in terms of the 100-day challenge.
I think it's so I'm just going to cover the Devon and Cornwall shared care record. So I'm Jane Bullard, I'm part of the commissioning organisation. And what we've done as the ICB is commission something called the Devon and Cornwall shared care record. And that is a platform basically where a lot of information can sit about patients, because we know that a lot of organisations have got their own digital records and the information isn't shared across the different organisations that need to know. So, for example, the GPs will have information that and things that they've done that isn't shared with the ambulance or not able to be shared with the ambulance, and then it's not shared with UHP. And the one piece of work that we've started with on this is something called the treatment escalation plan. So the treatment escalation plan is a document it's a tool for people who are end of life to kind of really discuss with the clinical, with the nurse or the doctors about what they want if they become unwell. So it's around whether you want to be resuscitated. It's a joint conversation and it's a joint decision. So it's not the clinician making a decision, we are going to resuscitate or not. It's a conversation and a realistic conversation about what could happen if you deteriorate. So this tool, the treatment escalation plan, has been around for a long time in different guises, and we're on version 12 now. But what we have done using the Devon and Cornwall shared care record is to put this form onto the DCCR, sorry, go into abbreviation, put it onto the DCCR so that it can be visible across the whole of our system partners, to SWAS, to GPs, care homes and to UHP. So it's a big step forward, and having the treatment escalation plan on this shared care platform will help us to make better decisions for patients, and realistic decisions. So, for example, the work that Shane and Sharon have done in care homes, one of the feedback is that they haven't got enough autonomy to be able to make decisions for their residents, and this will help them for the visibility of the treatment escalation plans that are in place. So it covers care choices, do not resuscitate, and also looks at mental capacity as well. So people making a decision about mental capacity. So, and we have we've set up lots of different resources. So we've done an overview of the TEP and what it means for us as professionals. We've also done a public information video based on some of the feedback that Sharon and St Luke's have put that together for us, which is great. We've got a new end-of-life website, which is a Devon-wide thing, but we have put a lot of this information on there. And we've also got a resource library, and we've got information leaflets. So we've tried to go a long way to try and meet some of the needs that's been recognised by the work that our partners have done, to try and kind of plug that gap and make a lot more things visible throughout the system.
Okay. Before you go on, I think there's probably a couple of questions about the TEP. Can I just ask, when you're talking to the resident or the patient about the TEP form, do any of the other members of the family get involved, or are you just talking one-to-one with somebody that possibly could have the onset of dementia, so don't really know what you're talking about, but you as a doctor or whatever, you don't really you can say that they actually can make their own decisions. So I'm just curious whether the family would get involved.
There's a big section, and one of the things we know from the work that's been done over the years is that the mental capacity bit is the bit that's the hardest bit to kind of fill in. I will pass over to Sharon, but we do recognise, and there's a big mandatory section of the form to make sure that mental capacity has been assessed, and if it is up to the patient whether the family are there or not, that so if they are deemed to have capacity and they don't want their family there, then that is their decision. However, if there's any questions around capacity, then that is addressed by the clinician. But I will hand over to Sharon because she might be able to add something to this as well.
Yeah, so it can be really difficult sometimes. So in emergency situations, the family may not be there, so it's hard to have that conversation with the family at that time. But as soon as the family are there, the conversation will happen with the family as well. And like Jane said, if the person's actually got capacity, then it's with their permission that we talk to somebody else. Otherwise, we do involve family in those discussions, and the expectation would be that any decisions that are being made about that person are shared. It's like no decision about me without me. So we would be having those conversations with family and people close to them. And we can also, so if somebody hasn't got capacity and they don't have family or anybody else to speak for them, we would also be thinking about getting an IMCA involved.
I understand what you're saying, Sharon, but I'm trying to get at, if somebody, how do you know that somebody's got capacity? That's my question, because if somebody's got the onset of dementia, one day they might be fine and then the next day they might not. So my question is, how do you define that that person has got capacity?
So capacity is assessed on the decision at the time. So if somebody's capacity is, as you say, we call that fluctuating. So yes, I mean, some people can have capacity at certain times of the day even, and not at other times of the day. So it's us picking the right time for that person to have that conversation. And my expectation would still be that the family are involved in that decision making with that person as well.
Well, I would hope so, but I know that's not happened in the past. So, Natalie. Sorry, I've got councillors that want to ask questions before we move on. Is that all right?
Thank you. I want to go back to the previous slides, the 100-day challenge. So I'm not sure whether it might be Chris or Sharon that might want be able to answer this. You talked about extending the administration availability of IV, antibiotics, fluids, etc., to care homes, and sometimes patients, residents are brought in because that's needed. Is that down to staff training? Is that CPD? You know, that the care homes, residential homes, do not feel that they have the, are able to give those rather than just purely the availability of it. You know, is there something about training and making sure that our homes feel confident to do that?
I think probably we'd all have something to say about that, because it straddles quite a few of our services. But some of the work that we've been doing with our ED practitioners, our ED end of life practitioners, are around, at times people do need to come into ED for a chest x-ray or a specific type of intervention that establishes what regime they need to be on. And I think the challenge for us is around, after that's done, getting them back to the care home to receive that treatment and not necessarily being taken onto a ward where they don't necessarily need to be, where they might potentially be confused, where, you know, all those other things start to come into play, and they're on bedded care then, and it's very difficult to at times get people home after being admitted. So there is a piece of work going on at the moment around our ED practitioners working around a pathway to enable people to have that assessment if they so need it, if the GP, if there's not the confidence to apply that in the home at the point they've decided that they may need it, coming into ED, having that stuff worked up, having that plan worked up, and then for them to be picked up by the community IV team. So, just from an ED perspective, that's something that we very much are looking at the moment.
And also, just to answer that question as well, we've got a care home clinical reference group, which is all of our GP partners, and we're working with them to make sure that they know, that they decide when IVs are appropriate and whether they can be given in the home and who does that. So that's a real key piece of work for our primary care partners as well.
Alison?
Thank you, Chair. Can I just confirm that the personal data and NHS number that appears on one of these slides is fictional?
It definitely is fictional. It's a test patient, so it's not a real patient that's
No,
on there.
thank you. Just want to be clear about that.
Yeah.
But my question is, when you were doing the work leading up to the recommendations for the 100 challenge recommendations, and you were talking to care homes, what reasons did they give for sending people into hospital? Was it, relatives wanted patient treated? They didn't have the expertise with it in-house to deal with it. Perhaps it was a medical thing that they needed. I'd be interested to know how that discussion went on and how that's been leading to change.
So there's various reasons. Sometimes it was that the care homes didn't feel listened to, maybe by other professionals, and the patient's wishes. So they said even though they knew some of their clients really well, they may have a professional that came in that actually overrode that. It could be, as you say, what the relative wanted. And they felt that sometimes relatives didn't necessarily listen to them, but they would listen to a professional. So they were explain. There's a process to death very often with the majority of us when we're coming to the end of our life. The care homes know that process, but families weren't necessarily believing when they said this is part of the dying process. But when they had a professional, say a district nurse or a GP or a paramedic come in and tell them the same thing, they were believing that. So hence the reason they said it'd be really good if we had an information leaflet with all of our professional logos on, because they felt that that would probably be more believed. So there was lots of reasons as to why people were going in. Some of it was around the training in the care homes and them maybe not recognising that somebody's health was deteriorating as quickly as it was, and maybe somebody had a fall. Lots of reasons why people were going in. And that's not to say that all of those conveyances to ED weren't appropriate. They were absolutely the right thing for some of those residents living in those care homes.
John?
Thank you, Chair. 2 points. I didn't raise it earlier. One was, since I've retired, which is a long time ago, I thought most PCNs, which are a new thing, had come to some arrangement where care homes in their patches, or many of the care homes and linked to GP practices, had designated visiting teams from paramedics or medical practitioners or whoever, who weren't necessarily, trying to juggle the day-to-day general practice work with routine or emergency visiting in care homes, which is quite a complex area. So is that fairly widespread across the city? Does it vary from PCN to PCN? Are the arrangements different? Who does it and how it's done? That's one question. The second one, a bit of an observation, is regarding TEP forms. Certainly I had a cousin, I was the next of kin 6 years ago, had one signed up more than a year before she died by the GP practice. Neither they nor the home let me know it was in existence until there was a crisis a year later. My mother had one signed up about a year ago when a community nurse visited to dress her leg. My mother's fully got her marbles, so she was quite able to make the sensible decision. But again, she did show it to me, but there wasn't any attempt to make contact with me to say, we've done this. I mean, I was a little bit surprised that she was just having her leg dressed, and I went in and she showed me this form. So, are we actually involving the people we should? Unless, of course, the patient says, I don't want anyone involved, and they've got the capacity to say that. So 2 points there, one on the visiting in nursing homes and care homes, and one on TEP forms.
Thank you, Councillor Mahoney. In terms of the PCN offer, each PCN has signed up to the Enhanced Healthcare in Care Homes framework. So there is quite a robust framework that's like a national edict now. And each PCN has signed up to a direct enhanced service to do with care homes. And part of that is a weekly ward round. It doesn't have to be kind of in person, but there's very much a kind of a push for each PCN to have the kind of standardised service, and we're monitoring that as well. So we're monitoring the number of structured medication reviews that take place in homes and trying to make sure there's advanced care plans in place. So we are monitoring that. So it's improving, and for all of our care homes in Plymouth and West Devon, we have got an aligned PCN, and we've got care home leads which come to the clinical reference group. So we're probably a year in now, and we're definitely seeing an improvement in the primary care offered to care homes without a doubt. In terms of the TEP form, I think we'd all recognise that there's improvements that could be made, and I know the audit that we've done at the hospital and in the community through the care homes, and this is why we've brought in a much more standardised approach, which makes it much safer for patients to kind of understand, and we're very kind of clear that we want patients to understand what that conversation has been about, and the families, if the patients are happy, the families to know. So we're trying to really improve the quality of the TEPs in terms of capacity, but also making sure that there's a wider understanding across our community of what TEPs actually mean and how they're used, which is why we've done all the resources. Does that help?
Stefan.
Thank you, Chair. My question has been answered in a previous question. Thank you.
Patrick.
Thank you very much indeed, Chair, and thank you, Jane, for sharing the shared care record process, because I think that certainly will enhance it moving forward. My question was just around the practicality and the ability for residents in the community to be able to get one of these completed. Is the first point of call the GP surgery, and can it be any healthcare professional that takes an individual through the completion of this process?
Well, we've got the amazing Sharon, who has been training nurses, a lot of our nurses in the community, around completing TEPs, because often the GP, it has been the point of contact as time's gone on, but we've now got quite a lot of frailty coordinators in our community, and part of their remit is to do an advanced care plan and talk about what do you want to happen. And do you remember last time we were talking about frailty? So this is tying in with our frailty agenda. So we're trying to have those conversations upstream, so we're not having them in an emergency situation where relatives don't know. So we've got a really good method now to try and get a lot of more people trained to be able to do treatment escalation plans as a joint decision. And we're trying to even train care home, senior registered managers in care homes to complete TEPs as well. Because again, they're having the conversations with the relatives, they're professional people, and it seems the most appropriate way, that rather than, not in a horrible way, but dragging the GP in who maybe not have that relationship with the family yet. So we're trying to make big strides to get more people to be able to have these conversations in a proactive, calmer way, and we're not trying to, so it's not done like the last minute.
But who's their point of contact? How would they access that?
A lot of it is as the primary care or whoever's in charge of the care is seeing a deterioration. So it's and one of the things we're trying to do as part of this work is trying to recognise end of life earlier. And so as soon as the primary care and as we talked last time about the gold standards framework or any way of identifying end of life, those are the kinds of people who are looking for those signs and symptoms of the last year or the last stage of life. Those are the people we'd be expecting to start having those conversations.
Thank you, Chair.
Anything else to add? Sorry. No.
I've got Will, and then we'll move on.
I think that last answer my question away is about obviously the people working with the patients or the carers, whether that's a care home, it's knowing then they might recognise the changes or the things in the patient, suddenly less able or illness and things. So how do they? Okay, sometimes when somebody's working at the coalface necessarily, lots of these things are taken by people above them, but do those people have the carers and the people giving the care, do they have a knowledge of where the feedback that they're giving, and perhaps if they fill paperwork out or patient notes, when they give that feedback to do they understand how that fits into the process of what feedback they're giving about their patient or reporting about their patient goes into feeding into this sort of longer strategy?
Sure, yeah, absolutely, Councillor Noble. That's what our strategy is, to try and get more people trained around end of life, and especially in our health and social care workforce, that they kind of understand what we're looking for, and what people can do about it. So it's just a lot more visibility and a lot more talking about the end of life kind of phase.
Mary.
Sorry, can I ask your indulgence on this? Do you then record it on their patient record that has happened, so that if I go in to somebody and talking to them and they say, oh, somebody asked me some weird questions, that I can look at and say, oh, well, yes, it was the tech that they were talking about, and explain, so that somebody knows, that that's happened.
Yeah. So one of the things that we know, that I don't remember at the last meeting, we talked about an end of life register, and that in our locality we're not brilliant at recording those end of life people who might be nearing the end of life. So that's one thing we're talking about. We've prioritised as an end of life locality group, is how do we get more and more people recognising that people are going into that end of life stage. And we've got something called EPAC, so it stands for something. But anyway, we're trying to get the form that gets people on the end of life register onto the DCCR. Does that make sense? So the TEP's on there. Our next mission, we're hoping by the summer, is to get a form on there where people can go with, they're on the end of life register. Everyone in the system knows that that conversation's been had, and here's the associated TEP. It's a big piece of work, but it's really important, because I think it will increase quality of patient care in those kind of last stage of life. But yeah.
I think there's something to add to that. So each of our organisations, we don't all run the same IT system, but what ETEP brings to it is one shared place where all of our systems have a road, a road into that single point. So even though perhaps somebody at Derriford might have had a conversation around ETEP, when they come home and perhaps our community colleagues are using system 1, they still have the same road network that takes it to the DCCR system to have sight of that ETAP, which is one of the greatest bonuses, to have that visibility across organisations and settings.
I think what I really, really need to know is that the patient knows that that conversation has happened, and that it's a TEP conversation, not how are you today, Mrs. McGinn's, blah, blah, blah. And they don't know that that's happened. And I think that's the one thing that concerns me. It's coming back to what Pauline is saying about somebody that has capacity 1 minute, then 2 minutes later hasn't, that may not, that person's relatives may go in when they have not got capacity, so they don't have a clue. Yeah, so it's making sure that that's communicated as well to relatives.
Part of the process in the rollout is to improve that, and that's why we're putting a lot of training in. And also we are saying to across the board that it's a patient-only printout, but we're also looking in the future at making it available on the NHS app. So that's a part of the rollout. We're hoping by next year that would be something that would be in place, which will be a game changer, I think, in terms of, I know that not everyone's digital, I get that, but, it's publicly available. It's their document. This is about their death, not our death, going back to the opening slides.
Okay, I'll take it, Kath, go on.
Thank you, Chair. I'm just wondering if there are some patients who don't want their relatives to know that they're dying because it might upset them, and how do you deal with that?
It's a very tricky one. I know that a lot of our practitioners are in that, that position but I think we've got a lot of skilled people out there who know how to navigate this, really well, and we would always encourage them to talk about dying with their family.
Okay, we're gonna move on now.
Sorry, it's me again for a little bit, because I'm a bit geeky in terms of stats. So I'm going to do the stats bit of this project and then hand over to Karen. This is Estover project, and it's involved a lot of partners. And this is just a project that we want to talk about that we thought you might be interested in, and kind of where it's come from. So one of the things we've done in the past is look at the different people in our community. So I don't know whether anyone's Public Health have got something called Mosaic, which we use to segment our audience. Yeah, you know that? Yeah, sorry. Yeah. So one of the audiences we've been looking at is vintage value. I know it sounds awful, but these are older people who are less affluent. So people are more likely to be on pension credit, more likely to have reduced incomes and have fuel poverty. So we're very interested in this segment of our community, because we know this segment of our community are more likely to need urgent and emergency care. So we're trying to find out where people in this segment live, and to see if we can improve the care for them locally, so they avoid these kind of fires within their lives. So what we've done last year, we looked at all of our ED attendances based on the geographical postcode of this segment, if that makes sense. So this is known as the blob map, because we've got the red blobs. So I don't know if you can see. The redder the blob, or is the more likely people from this segment are going to be going to ED. So for us, this helps us kind of really indicate where our older people who are less affluent are attending ED more. Some of them might be care homes, but we know that some aren't. So what we managed to do, I don't know whether you can see the Estover. I'm sure you're all very familiar with the Plymouth map, but can you see the Estover area? There's quite a few red dots around there. So we kind of honed in on that area, because it's kind of a new area for us. And we thought, what's going on there? So then we did a bit more of an in-depth. So this is Estover area. So you can see there's 4 dots there. And those 4 dots are where we've got high attendance of ED for this segment. So we drilled down even further. And then we had a look at all the postcodes and trying to find out how many attendances in the last 2 years were from there, and what kind of accommodation it was. So you can see there at Leigh Park, when I was doing the vaccination work, I went into Anchor Care into Leigh Park. I was like, oh my goodness, this is where we need to do a lot of vaccinations, but it's also where a lot of people were living in single flats and had comorbidities, a lot of long-term conditions. So that's one of our red dots. We also had Keswick Crescent, which was on there. So that's social housing, Wasdale Close. You'll know all these areas. A lot of this is PCH homes. So we did do a deep dive. We then used this information to then look at what is the causes of death for a lot of the people within these areas. And we found that there was a higher rate of COPD and a higher rate of lung cancer in these areas. As you can see, I'm sorry, I can't make it a lot bigger because then you lose, but I hope you can see it on your maps. It's higher than the average across Plymouth. So that kind of gave us a bit of indication about actually there's more COPD in this area, and more people living with kind of respiratory problems, which you might associate with the more deprived areas where there's higher smoking rates. So it's kind of like backtracking around public health. So and then we've had a bit of conversation with all the partners in this area, and with our Plymouth Community Homes, which backed up our findings. They said, yeah, absolutely. There's a lot of people living with COPD around Estover who have moved from our more deprived areas of the city. So it's kind of like, right, what is that telling us? And so we have joined with Marie Curie, which Karen will go on to try and come together and really kind of understand the needs within this community, and around the deprivation. So I'll hand over to Karen now, who can just talk about the project a bit more.
Hi, I'm Karen Bertha. I'm from Marie Curie, covering the Southwest, and I think it's a really exciting project, and building on from some of the conversations we've had around TEP forms and identification involving people. I think this project, there's an awful lot for us to learn from this. So one of the key outputs for us really is to help the population of Estover and all of the health and social care professionals working in Estover to identify people that are approaching the end of life. And the reason that's important, so we can look at an understanding what matters to them, what they would like to happen, where they would like to be, and also involving as whatever their family looks like around them. So the project we're putting in is a registered nurse, a senior registered nurse working in and around Elm Surgery with the multidisciplinary team, but we're also putting in a volunteer services coordinator and some volunteers, so taking a community engagement approach. So we're coming at it from two angles, from a kind of professional angle, but also a societal angle. We all know, as members of society, we're rubbish at talking about death and dying. And actually, if we don't talk about it, we got no chance of improving it or having our needs met. So it's a 6-month project initially. The key thing is about learning. What can we learn about what's going on in Estover? What can we learn about what makes the biggest improvements for the residents in Estover, but also that knock-on impact onto the health and social care system? And then what is replicable around that? We're starting off, we've started the project 2 weeks ago now. We've got the people in post, and we're spending 8 weeks just trying to get absolutely absorbed into Estover. So Councillor Noble, you are on our list. We want to come and understand who works in Estover from a professional point of view. What's their view around their part in end-of-life care? And we've already had some quite interesting feedback around, I don't know, we don't have anything to do with end-of-life care, when actually I think clearly they probably do. But also from the community's point of view, what's their view of end-of-life care? What should it look like? What should it feel like? And what's their experiences of friends and neighbours dying? Because that view will impact on their view of what could happen and what would be nice to happen. So we know that there's a high proportion of people going into ED. As we've touched on before, is that appropriate? Is that not appropriate? Who decides whether that's appropriate? So we'll do some case reviews on understanding who went into ED, why they went into ED. But from that community approach, actually, how did that feel for someone who lives into Estover going into ED? Was that a good experience? Did they want to go there because they felt it was the safest place to go? And therefore, that in itself is unpicking, well, okay, how can we make someone feel safe without having to rock up to a very, very busy ED department? How can we look at that? So we're going to take 8 weeks. I know it's a short period of time, but what's already struck us with Estover is there is so much going on there. So I think what's going to be really interesting is taking the 8 weeks to look at what the jigsaw puzzles are. And it might be that we find there are some jigsaw puzzles missing, or it may be we just need to put the jigsaw puzzles together in all of this and look at how we can keep them together. So there's a long list of partners that we are already engaging with, but as you can imagine, with every person we speak to, we get another 3 people to speak to. So that's what we're looking at doing. And we're looking at working obviously closely. St Luke's going to talk in a minute about the compassionate city stuff. So really linking in with people already there. We're not looking to duplicate. None of us have got the resources or the time to duplicate what's happening. So it's about how we all work together and understand the different work that we can do together.
John?
Thank you, Chair. When we're talking about ED attendances here in the Estover area, we're not just talking about ED attendances that are relating to end-of-life care, are we?
Yeah.
So, I mean, there are lots of reasons why people rock up at ED, and part of the reason in Estover might be because they live so near. So, do we know what proportion of those attendances are related to end-of-life care? One would imagine that lots of people who are near the end of life wouldn't just rock up at ED because they wouldn't be able to do it. So I wonder whether we're confusing two things here.
With public health, we'll try and target down as much as possible in looking at that specific cohort as much as we can.
And we have looked at the admission rate, and we are finding a lot of respiratory infections from that community, a lot of exacerbations. So we know that it's not, that there is a proximity. There's a lot known about the closer you are to ED, the more likely you are to attend. But there's other factors that are affecting that as well. So we're kind of almost certain that it's not just because they're close.
Well.
It's really interesting that Estover's, been using your case study. This area we know as the Estover Alps because it's quite hilly, but obviously obviously we've got the Elm Centres transitioning to a wellbeing hub, so they have the COPD clinic there, which I think is quite well. Well, I think that serves the city, but that's quite well used. Obviously, a lot of the housing here, some of the housing are residents that moved in when they were allocated a house in the 70s and they still live there. So as they've got older, their health needs have changed. And there's a lot of the housing, the bungalows and things, people move in from other parts of the city, lots of older people. So obviously, when people decide to downsize, I mean, that's I suppose that's done from a housing point of view, but would there be an opportunity for people to start thinking about some of these? Obviously, if you downsize, you get rid of things, and people might put their affairs in order, so to speak. Is there an opportunity to perhaps start people thinking on this? Oh, my health, and I've got these health conditions now, and that's not going to get better. But how do I plan for the future? So. Is that going to be something that perhaps look at only an early stage of your project?
That's absolutely what we're going to do. And the conversation earlier around the treatment escalation plans, ideally where we want to get from an end-of-life care point of view, that's not the first conversation you have about the end of your life. The conversations are, we all have moments in our life where we need to think about our own mortality, whether we like it or not. So when someone else dies, it makes us think about our own mortality and what we would like to happen when we downsize. They're all opportunities for people to stop and think about what is important to them now and what they would like to happen to them as they approach their end of life. So we talk about advanced care plans quite a lot, and we probably touched on it last session, we will later. That's the kind of precursor, that's the important bit from my point of view before you get to a TEP. That is the time you sit down with your family and go, do you know what? I am getting older, I am getting frail. If this happens to me, I want this to happen to me. I want to be here with you sat by my bedside and my dog next to me. And those conversations make the conversations then around the treatment escalations so much better, so much richer, and more likely that we're going to help people achieve what they want.
You've used the mosaic system is like a marketing, isn't it? It's a way of segmenting the population. It's used by marketing companies as well, isn't it? I think my house is it must be on an L because I get some from lots of odd mail because the previous occupants were in their 80s. So, has that approach been of using these marketing segmentations and mosaic? Has that been used before, or is this something is this a methodology that's being tried out?
It's been used somewhat before. I think me personally, I've used it for about 15 years. I know that Public Health have had the license and they've used it, within the council. I believe it is used well in other areas, but there are different models on the market. There's different geodemographic tools, there's Acorn, and there's Shape Atlas now as well. So there's lots of tools out there, but I think we as NHS, we could use these tools, marketing tools, a lot more, and this is just one way that we've used this particular tool. There's lots more options we could do.
I see that you're working with Plymouth Community Homes. Can I just ask, what are Plymouth Community Homes going to do? Because what are they? They're going to be working with you. So is it to improve the housing conditions? Because with all due respect, some of the houses and some of the houses with Plymouth Community Homes are not what I call up to standard. So are they going to improve those properties, or I just need to know what their role is going to be if they're being a bit of a partner with you for doing this. I just...
So from a project point of view, as Marie Curie working with the local, that's not for us to solve, to be clear. What we're working with them very closely is that the residents of Estover that we want to work with are living in their homes, and they have various teams and they have various meetings and they have various communications. So we're working with them. Again, they'll have housing officers that might go, actually, Molly's a little bit more frailer today. So working with them so that they know from an end-of-life care point of view and a health and social care point of view who to link in and work with. I guess through all of this, in some of the findings, that's for us to work with our partners to identify what we have found. So,
yeah, and there is there's a joint post, Rachel Fox, a joint post that's sat within Plymouth Community Homes. She's jointly funded by Health and Social Care. Sorry, she's not. Live Well. She Live Well and PCC, I think. And she's part of the project, and she's already done huge amounts of work with this project, and she's fabulous. So yeah.
Okay, I mean, I'm just flabbergasted that we've got all these partners working together. So if they're not going to, you're trying to do all of this good work, and then maybe a stumbling block is maybe some of the living conditions that people are in. That's not going to improve their health or whatever. I just don't understand. Am I just not getting this summary?
They do have a damp and mould team, which Rachel's in contact with, and I think this will be part of the project, is how do we liaise backwards and forwards with PCH? Go on.
And again, it might. So just from my previous professional work, I did a lot of work with not just PCH but other housing associations around adaptations in the home, possibly thinking about if we're getting there early enough around house moves, because that can really make care at home achievable in the longer term. I think there are people in the system. There are allied health professionals that work with PCH, and very often they have other housing associations have teams that work with adaptation, so that there is a very clear piece of work around the environment, not just around poor living conditions, but adaptations to living conditions which make home achievable. There are real restrictions around bed space, stairs, bathing facilities, which really restrict care at home as an option. So if we can get in there early enough, and I think there might be some interesting data that comes out of this test bed, if we can work closely with PCH and other housing associations, that improves the chances. Again, if we're in there early enough, there are some really meaningful bits of work that we can do.
Mary?
Just to say, Chair, that Councillor Penberthy at the moment is looking at housing needs assessment across the city, and it may well be that you feel there's something that this committee can put a recommendation to him to be thinking about it. I mean, we know there's not enough bungalows and things like that for older people in the city, and he's always after any of us find any little clumps of land that we could refer to him for house building. He's always really happy to see that. But I think it might be quite useful that, you know, as you say, the housing stock is getting older, and you know, we know that PCH have limited funds, the same as everybody these days have limited, but it might be a recommendation, Chair, that the committee might like to think about.
Paul?
Thanks, Chair. I'd like to ask Jane, when someone comes to ED, you know their age and where they live, but how do you extrapolate from that which mosaic group they're in for all your further work?
So it's not on an individual person. So the mosaic group belongs to a what's it called? SOA, super output area. So it's at a super output area level. So the person doesn't have a classification. The area has a classification. So the mosaic says to us that super output area, but the predominantly people who live there are vintage value. So, and often you'll put your postcode in, you're like, oh, actually that does match what it looks like. So it's not the person that's got the classification, it's the area. So it's just that we've kind of put two bits of data together. Does that make sense?
Yeah, but obviously there will be problems because not everybody in the area will fit that.
Oh, yeah, absolutely. But it's that generic kind of, we've got to kind of start somewhere, because without putting everyone into a different category, we've got to use some kind of geodemographic profiling. And this is where the Tesco's and, Morrison's, and this is why we get leaflets through our doors that you think, what? Why do I need that leaflet? Because they're using the demographic profiling tools that are out there. So it's a big tool that's used in marketing. I'd love to get to the point where we have a specific public sector club card that would give us the kind of information that our private sector and Tesco have got, but we're not there.
So I understand that you want to declare an interest.
So I'm normally told I don't need to, but as there's an in-depth conversation about PCH, I think I am a non-exec director of PCH.
Right, that's what you wanted to tell me. You haven't. No question. Okay. Stefan.
I just wonder, today in our society, we have more and more people living on their own. And a recent experience that I had with some of my friends was that they have fallen and ended up with a stroke, and nobody, absolutely nobody, came to help and assist for a good 12 plus hours. Now, knowing that older population tend to fall, and what measures do we have in place to ensure that we have some sort of contact with those individuals that are vulnerable? Because some of the stories that I heard where people died in their homes and they are discovered 2-3 years later is something that really, really horrifies me. And I just want to find out what you, with this program, are intending to do to ensure that those individuals that are living on their own are being protected and looked after in the proper manner. Thank you.
I think that's part of the project as well. I mean, it breaks our hearts, when we hear stories like that. It's, that's just no way to go, is it? Yeah, I mean, I think one of the things that's very much on the agenda nationally is how does our housing match the needs of our population? How can we put remote monitoring in place? All those kind of things that might help keep people safe. There is an element, though, that people might not want that, so, we do have a lot of people out in the community that don't want to wear the pendant alarm. I remember trying to get my gran to wear one. But I think that, you kind of got to balance it with people kind of taking their own, they're empowered to make that decision, but also putting things in place when people, do want help. So it's that balance, and I think that's something we can work on throughout this project, is the more that we could put in place to keep people safer.
Well,
I know they're perhaps a little bit following on from what Stefan's just said. They do have so the PCH bungalows, because people complain that they've got to pay for a phone line, but the PCH bungalows have the call button, like as a standard, if you like. And is that something, perhaps a recommendation for standards going forward? Is that something you'd like to come out of the project?
I don't think at this point I'm going to judge anything that comes out of the project, because it would be unfair. I think we need to do the 8 weeks really understanding what's going on. But your point around PCH and the call bells, they're on our list to talk to as well, to understand from them what the kind of experiences are. So that's what we want to understand and learn, really.
Sorry, I think Gary can answer this question.
Hi, Will. I think, and the question from Stefan and yours, Will, I think the issue of falls is a whole subject in itself. Whilst we would recognise, if we were drawing the Venn diagram, there would be an aspect of people in the end of life process that were also subject to falls. So I think it's just probably hard for the team to answer some of those questions, because that is, and I know when we're involved in our other conversations, falls is an entire subject like this that you could almost bring into sessions similar to that, and the things you bring up around pendants and all the different other options that are available to people. I think there are quite a lot of things around that services do for that, but I don't imagine it's the specialist subject for everyone here, but it will be part of, sadly, people's experiences and end of life, as well as lots of other people in our communities for lots of other reasons. So just wanted to add that, really.
Thank you, Gary. I've got John, and then we're going to move on.
Yeah, just an observation for the future. If BT and whatever Openreach does what it wants to do, by the end of next year, nobody will have an ordinary landline. So everyone who's got one of these pendants that requires a phone line, it won't work. I mean, there are alternatives. They go through the airwaves or whatever new fancy things they do. But I mean, is a whole adult health social care department aware that, you know, allegedly within 18 months or so this might happen? My view is it probably won't, but it's going to be a lot of upheaval for all the people who've got pendants who use the phone line, which is the majority of them at the moment.
And again, the subject in its own right, but it's something we've been talking to communications organisations about. There's been a whole programme of working, because actually they're in that implementation phase, and those things are being considered for all those other schemes. But it's another subject in itself. But that is something that commissioners are working with providers on in terms of having to manage the transition, and something that BT and others have got, you know, specialist project work on, recognising they know there are some people in communities that will find that transition or may have other equipment issues coming up. So it's been a long-standing programme.
Okay, we're going to move on. Thank you.
Just like to introduce Francis here on the screen.
Morning, everybody. And I should just start off with a little declaration, I suppose, that I've been in post at St Luke's as Associate Director for Quality and Patient Experience for the last 2 years. And within my remit, I support the community development team that's funded within the St Luke's charity. However, I'm going to be talking a little bit about Compassionate City, which started back in 2018, and I'm aware that many of you in the room were probably part of this and have more knowledge of it than I did. So I apologise in advance if I misrepresent anything which I'm saying, but I'd love to be corrected by you. So really, the notion of Compassionate City was very much an international idea, and it's really taking a public health approach to death, dying and bereavement, and recognising, as a quote that we had at the beginning of this session by Alan Keller here, who's an academic at the University of Bradford. And he said the larger part of dying happens outside of the institution of professional care. So it's really recognising that actually as communities, we are supporting living amongst the normal cycles of sickness and health, birth and death, love and loss. These are daily activities in all our lives. And yet, particularly in Western societies, talking about death and dying has become very much a taboo subject. And the Lancet review into Understanding Death, which took place 2 years ago, showed how it's become more and more in the Western world, death is seen as a medicalised issue rather than a normal part of our cycle of death or cycle of life. So the Compassionate City was recognising a public health approach to death and dying and bereavement, and really saying, how do we find those spaces where we have where we have large groups of people who are already together, and creating those spaces to support one another. So it's really a civic approach, thinking about schools, workplaces, places of worship, hospices, nursing homes, museums and art galleries. How can we all come together to really think about, start talking about normalising death, anticipatory bereavement and bereavement? And this is a really good example back in 2018 when we started thinking about it as a city, where we really came together as a city, all different parts. So we had the council, city council, Ruth Hurrell, very involved, councillors, Derriford Hospital, the CCG, Live Well, Plymouth Octopus Project, Shekinah, Marie Curie, St Luke's. We all came together, and there was a real aspiration for what can we do. And focusing on it as a compassionate city, there was a concept developed by Alan Kelleher and Julian Abel of this sort of charter. So there were charter points, so that there were 13 different charter points which we would address as a city, and that we created a steering group. There was a lot of momentum. There were groups working on what we can do in schools, what we could do in workplaces, what we could do thinking about things like peace parades. So in the same way we have a military parade, how do we have a parade where we can recognise and celebrate those who've died and we've lost? This was back in 2018. And it was really, there was a lot of drive from a lady, the deputy director of St. Luke's, as was then Gail Wilson, really drove it from a St. Luke's perspective. Then, as with so many things, the momentum was growing, and then COVID came along. So if we can have the next slide, please. And I think what COVID showed us was this was the natural evolution. Rather than trying to create the strength in communities, we saw naturally, without any intervention from any other groups, the natural community spirit. So, you know, all of the things which the compassionate community had tried to really escalate, COVID came along and did it on its own. But what also happened was the energy and focus dissipated from the concept of the city. I think we had a lot of different leaders who were involved in the steering group left their posts. There was a lot of other focus on things that needed to happen, and other initiatives started, such as Belonging to Plymouth, Reducing Loneliness and Isolation Forum. The Thrive group started picking bits of the work that Compassionate City had started. So thinking about Compassionate Friends, it was starting to be driven through Thrive. So whilst I think the focus on Compassionate City may have dissipated, I think the legacy has been left in lots of different ripples have been left in different parts of the work. So I think we can see that in the Belonging Plymouth, in the Welcome in Plymouth initiative, in trauma-informed work, in the work we're doing with schools. So within St. Luke's, we are still funding 1.2 whole-time equivalent community development workers, and they are really focusing on how we normalise death, dying and grief, and the conversations we have about that. So I think all of the conversations we've had this morning about thinking about advanced care planning, thinking about treatment escalation plan conversations, which is a conversation, it's not a one-off event, it's a conversation that we ought to have regularly, and how we support our families and communities to start having those conversations and thinking about when we are inevitably getting closer to the end point of our lives. The community development team are particularly working alongside our community development builders who are now across the Plymouth patch. And we obviously, because we're from St. Luke's, we have a bigger focus than just Plymouth. We work alongside Devon and the strip of Cornwall as well. If I can have the next slide, please. So whilst I said the specific focus of the Compassionate City might have dissipated, there are elements which have lasted. And when you've got reduced, as we all know, when you've got reduced capacity, you have to think where best to use that energy. And what we've been focusing on at the moment is where there seems to be a real appetite. So the work we're continuing and working alongside our community builders, our PCC staff, people like Michael West, is to work with the schools. As many of you may or may not know, 1 in 29 children, so that's basically 1 in every class in a school, child is either has recently been bereaved or is facing bereavement. And what we're hearing from schools is that it's very difficult to know always how best to support those children and to avoid the conversations. So the work of the Compassionate Schools is to help schools understand what they can do within that big school community to help normalise talking about death and dying, to help schools have policies, because obviously schools are communities in themselves. So they've got teachers, staff who are also pupils potentially who die or are facing death, and helping the concept of compassionate buddies. So in a school, we might support children, how they support and have those conversations with each other about showing compassion, kindness, generosity, really focusing on the listening skills. And our team at St. Luke's are working with a lot of schools now, primary schools and secondary schools. And back in 2018-19, some of you might remember the Elmer competition where we tried to use art to help those conversations and get children through creative activities think about those that they've lost, death, dying, and that it's a normal part of the life cycle. This piece of work has also been done with the University of Plymouth, where we're using theatre, and the Theatre Forum come in and we use drama to help children think about how would you have these conversations. So there again, a really good example of cross-community, cross-institution working. We at St Luke's are still doing the Compassionate Friends awareness session. So this isn't training, but this is anybody can sign up to come along to a Compassionate Friends session. And that might be, in some areas, we might call it a friendly neighbour. But it's really about how people can feel more comfortable to have those conversations and to support their neighbour if they're facing death or if they're facing bereavement or when they're bereaved. We know from people who are bereaved that they say this is the loneliest, can be the loneliest time. And we know that isolation and loneliness is probably in itself one of the biggest public health issues that we face and can lead to premature death. So the Compassionate Friends, we've noticed less and less people signing up to be a compassionate friend to sort of make a formal pledge, but it doesn't mean that we're not upskilling people to feel more comfortable to have those conversations. But where we're seeing there's a real energy is in the concept of the Compassionate Cafe. And this is where we'll have different cafes who once a week or once a month say they have an open door and compassionate friends. So they're not formal volunteers. They're not part of St Luke's. They come up, they bubble up from within the community. So wards that your council is for may well have compassionate cafes where people are given the skills and anybody can come and talk about issues they're facing around death and bereavement and end-of-life care. And this is where they're growing. We've got about 10 across the patch now, so that's both within Plymouth and wider, so Kingsbridge, Tavistock, for example, Plymouth, Argyle, and a lot of these cafes will be connected to where we've got other community groups, so it's a really sustainable model. So a lot of the Compassionate Friends will come to a Compassionate Friends and then they might align with a Compassionate Cafe so they feel they have the skills and ability to talk to people about these sensitive issues. We're introducing Last Days Matter course. So this is really talking about what happens when we're dying, helping people start thinking about what happens at the end of life. There again, this will be aimed at anybody, so professionals, members of the public, people who are currently caring for somebody who's dying, perhaps somebody's dying themselves. This will be a 2.5-hour session. It was developed by St John's Hospice up in Lancashire. And I think this is something where we could really work with our community wellbeing hubs about coming in and using those spaces where communities are already coming together to offer this as an opportunity to really help improve our death literacy as a city. And we're continuing. So historically, for the last few years, we've been working with the libraries, and we have a circulating display which goes around different libraries where the librarians are also upskilled to have conversations about death and dying and to really help normalise that this is a part of the normal cycle and nothing to be tabooed. And that includes using the straightforward language. I think that's my final slide. Thank you.
Thank you. Alison.
Thank you for the presentation. Talked a lot about various strategic partners in all this. Can you also confirm that you're working with charities like SANS, Jeremiah's Journey, and how are they involved in all this?
Yep, that's a good question. Thank you. We did a big workshop this time last year for the schools where 45 different schools, primary and secondary schools, came along to talk about compassionate schools and what schools felt they needed. And that was a partnership between St Luke's, Jeremiah's Journey, Pen Halligan's Friend in Cornwall, and reference to Peach Dragon, but they weren't able to attend. And that was a collaborative piece of work. And going forward with the schools, I think there's enough work for everybody to be involved, but it's about each of us using our different skills. So the work we're doing in the schools, we're not working with specific pupils. It's more the concept of talking about death and dying and how teachers can support children generally. I think Jeremiah's journey are much more focused on doing that specific one-to-one work with specific children, but it's about collaborative working.
Okay, we're going to move on.
Thank you. So background to me now. So these final 6 slides, I'm not going to talk through in lots and lots of detail, but I will just go through them and pick out a few key points. So when we spoke last time, we talked about the statutory guidance, the obligations on the NHS, like the ICBs and the ICSs around end-of-life care, and particularly the guiding principles that are set out within the palliative care ambitions framework. So you'll have heard over the 2 sessions that we've delivered a focus around well, recognition to start with around the challenges that we've got within the city around end-of-life care provision, and we spoke quite at length last time, didn't we, around our appreciation of the difficulties and the impact that that's having. So what we've started to do is structure our work for the next year, or the next couple of years in some cases, around each of those ambitions and how we can focus the priorities that we've got in order to deliver the improvements. So the first ambition is seeing each person as an individual. So you'll have heard of some of the work already through the advanced care planning conversations, the TEP work that Jane described as well. Some of the other bits of focus that we know we need to take is around having that clear communication and training strategy. We've talked about making sure that those professionals who are interfacing with individuals are identifying and trained to have those conversations, making sure that we've got that clarity around the offers as well that we've got in place locally, through some of the work that was described around the care homes and the leaflets as well, how we can develop some of that. There's a further recommendation within the ambition framework as well around the offer of personal health budgets for people at end of life. So actually within Plymouth, it's something that we piloted and were at the forefront of prior to COVID, and had quite a strong offer jointly with St Luke's around that. It's something that's there's still an offer there, but actually how we embed that further is something that we need to come back to. There's a huge piece of work within this, and what we don't want to do is run the risk of distracting ourselves from some of the more core principles that we need to get right first before we come back to that. There may well be opportunities that we can go further with some of that activity in the meantime, but we've put it there at the minute as something that we'll come back to once we've got the basics right, really. The next ambition, making sure that we've got fair access to care. So again, we spoke quite extensively around moving away from individuals going into the emergency department or not having an opportunity to leave the hospital to go to a preferred place of death. So what we're absolutely, and our top priority is looking at the demand and capacity. So getting underneath some of the data to understand what's the capacity that we need within the city in order to support individuals in the community, thinking about what proportion of that might need to be bedded for people who want to go into a care home or a setting around a bedded pathway. Equally as well, our priority around supporting more individuals to return back home, so making sure we've got the right health and social care community response to support those individuals in their own home too. Again, looking at both that urgent and non-urgent service. So those individuals who might have had a sudden crisis, as well as those that it's more in a planned way. So looking at the totality of that to understand what's the capacity we need, what's the capacity that we've currently got, and then setting out our commissioning intentions as to how we're going to develop that offer moving forwards. Maximising comfort and well-being, so spoke around some of the Devon-wide activity in this place that's taking place around just in case medication improvement work. Development of the care coordination hub is a top priority for the whole of Devon, but that's going to have a local spoke to it that supports the local delivery for people who are in crisis. What we need to make sure is that our local delivery of that has a really strong specialist end-of-life input, and that's something we're going to be looking at and focused on. The other bit, picking up on the need to make sure that we've got a regular process for auditing end-of-life care, making sure individuals' priorities are being met. So we need to, make sure that we've got a process around that, and that's built into our normal commissioning approach. Care coordination, so again, making sure that we're using tools to identify people at end of life, getting them recorded on the register appropriately, and that we've got the wraparound support. We've spoken a bit around gold standards framework last time, but there are other models as well, and we're doing some work now to look at the different offers that are there in order that we can have a recommendation around what we want to embed for people within Plymouth. Making sure that we link into the work that's being done Devon-wide around the end-of-life service specification so that that responds to local need. Ambition 5 is all staff are prepared to care, so already lots of work done in terms of improving the training offer and embedding that across health and social care pathways, so both within UHP and Live Well, but also going further, so picking up some of the points earlier around care home activity, actually the broader health and social care workforce. What's our training strategy look like for those? How can we make sure that we've got a joint plan with Plymouth City Council colleagues to embed end-of-life training as part of that and support? And then the final one, Ambition 6, which absolutely comes back to conversation we've just been having and hearing around the Compassionate City work, but also an opportunity. We spoke last time around Dying Matters Week that's taking place 6th to the 12th of May. Actually, how as a Plymouth system might we want to take some opportunities there to make sure that we're raising the profile of deaf literature and supporting those conversations that need to take place. That kind of covers all of the ambitions framework. I thought it was quite a good place to kind of finish in terms of some of the work that we're doing, but really happy to take any questions around that or the recommendations further.
Thanks, Chris.
That's me.
Natalie.
Thank you, Chair. Just a very daft question. The 6 steps, I've had it mentioned, but maybe I've missed it somewhere, but can you just explain what the 6 steps are, please?
Sure. I might ask Trish, I don't know if you want to talk about that because it's St Luke's programme, isn't it?
Yeah, it's St Luke's education programme. So it's a classroom based and also visiting and working along staff in the care homes with the education team from St Luke's, but it's they're then affiliated to the programme, so we do a site visit yearly so that they've a care home that's gone through our 6-step, which is, like I say, a 6-step training programme, and then we bespoke it into the individual care home setting. So and then there's ongoing work to follow the care home for that following year, do some in touch training, particularly as there's new staff that have evolved and come and go in the care home, so that they get a standard and they're recognised and have a certificate to say that they're affiliated to the 6-step care home education programme for end of life. And the education team do, as I say, an annual appraisal of the care home to ensure that they've still maintained standards.
Alison.
Thank you, Pauline. Actually, the ambitions are quite impressive, and there's clearly a lot of really positive joint working going on moving forward. But can I ask, how are you going to track your progress? Well, at what point will we get a report back to the committee and to the council on progress? So, for example, just with TEPS, how is that going to be tracked and assessed in terms of reaching some of the goals that you've talked about?
So it's a really good point, and it's something that we need to embed. So I did speak last time about some of the governance approach that we've got. So there is a locality end-of-life steering group that all of this will sit under, that feeds into a Devon-wide group as well. And we have had some conversations about membership of that. Councillor Aspinall is having a conversation with me about, actually, can we bring her in her role in order to support and have that input and oversight from a council perspective as well. Very happy to come back at a later point if that's felt appropriate in order to kind of give an update and an overview where we are against that. But absolutely, that I've touched on some of the audit work, making sure that we're embedding that as part of regular practice, so that we can see that it is genuinely having an impact for individuals as well.
So could we recommend that you come back within 6 months, or would you think that was too soon or too far down the line to give us an update report?
So very happy to. 6 months probably is reasonable in order for us to give an update. I think there is a huge amount of work to do. So perhaps not everything will be completed then clearly, but in terms of giving you an update around the progress that we're making and some of the impact we're seeing, very happy to do so.
Thank you.
Does any, Will?
So we heard in the first session more perhaps the medical side, you know, the pressure, the aims you were trying to get from the hospital's point of view of getting, so you didn't have people there when they could be somewhere better at home, or, you know, in a better place for the hospital and for the patients and their families. And obviously you've heard today more about the other aspects of, you know, the patient, the community, the family aspects of deaf, because deaf's not just a medical thing, it's, as the statement said, about the community. So obviously some of the things might be more measurable, like the ambitions to do with the hospital and how they relate to the hospital, and how you continue to measure the are you going to look at metrics to measure some of the other community-based things? How will you collect the feedback to track the other bits of the ambitions?
Thanks. So we did touch on last time the NHS England work around vital signs, and that's a programme that offers us an opportunity to look at some of the different measures and actually identify and agree some of those metrics. So you're absolutely right, Councillor Noble. You know, there is something measurable around people who are going into hospital, although some of that is quite difficult to track round back to end of life, so locally, as you'll have seen in terms of the data that we spoke through last time. But what we really need is make sure that we're identifying those individuals who are on an end of life pathway and journey, and make sure then that we've got the right metrics in order to measure that, including things like you say around the impact that it has on other individuals and that person's support network too. So through that programme and through the work that we'll be doing locally, that's absolutely one of the things that we'll need to do quickly, is agree what those metrics are and then how we can capture those.
Just from the St Luke's Compassionate Friends Cafe, I've been going along to one of those, help, you know, as a volunteer for about 2 years now at Estover, and it's, you know, I think it allows people who have been bereaved, and also people who've had to deal with illness. You know, if you've been a carer and you've had the illness, people get really cut off. Their own health goes down as well, doesn't it, as you get older? And I think it's been really good. It's very difficult for people to get back, the family, the other people around the patient, to get back out and reconnect. And I think things like the Compassionate Friends, you know, that's help the wellbeing hubs combating that loneliness and things, which is not necessarily directly the end of life patient and issues there, but actually I think that, you know, really I think people have got quite a bit out of that. Our one developed to a Sunday lunch club, which is not a displeasure to do. So you know, but you know, there we go. That was because the people said, well, you know, we've lost our family, and Sunday lunch is something they used to do as a family, and actually they can come along. People from friends that they've made through the Compassionate Cafe. I think they've liked that because it's not people in their family, so they don't have all the kind of emotional ties and things, so they can be a little bit more open about you know, things that might have upset them that you couldn't discuss with family members. So, and that's been a really good aspect of, you know, St Luke's work that isn't the things necessarily that people traditionally might go with the brilliant hospice work and things that we heard about earlier. So, yeah, thank you.
Thanks. Well, it's the same. We have the Veterans Breakfast Club, so it's the same sort of thing. Thanks. Anybody got any more questions? Mary.
Thanks, Chair. Really, I just wanted to know about prescribing. We're talking about just in case medication, and thinking about some of the activities that we've had with certain people working to rules, striking, etc. Has there been, do we know of any problems with that end of life medication that people might need, or pain relief? I mean, particularly if you're thinking about St Luke's, getting a GP to prescribe something in the middle of the night and all of this. Have we managed to get around that and make sure that we can say, to the best of our ability, somebody is not having a death that they really didn't want because of some, a staffing problem, shall we say, or something like that? And I think that to me is what it's all about. What we've got in place, if it works, is absolutely brilliant. It really, really is. But if it doesn't work, what's plan B?
Thank you. So I think one of the areas around this, so just picking up the just in case medication, first of all, so there has been an audit undertaken by the meds optimisation team in the ICB who identified some challenges there in terms of understanding and use, and actually that's led to quite a big piece of work in terms of improving some of the literature around that and the understanding. So yes, absolutely. That I think that was an area that was identified quite early on as a area of challenge and issue, and that's something that this programme will work around to address. Trish, I don't know if you wanted to come in on this point as well, just to add further.
Yeah, thank you, Chris. An excellent question. It gets me onto my hobby horse. So, medication and non-medical prescribers is the name that we give to professional colleagues who are not medically trained but are excellent experienced practitioners. So my nurse consultants, for example, and advanced care practitioners, we're rolling out a really big program of non-medical NMP, non-medical practitioner training, and for me it's one of the biggest growth areas for developing really skilled practitioners to understand the pharmacological needs for the patient and understand what side effects they may be having on pharmacy, so that the one touch when they come in and assess them, they are skilled, able to have those conversations, and like I say, do it in a much more timely way rather than a nurse going in who previous days gone by as district nurses, we weren't trained in pharmacology and non-medical prescribing, so we'd have to go back and ask the GP to then go in and visit. That feels like that's a wasted and duplication of resource. So I'm really pleased to say that our number of non-medical prescribing within our clinical nurse specialist team is really rising, with the expectation that all CNSs will also be non-medical prescribers, so that we can have that first touch, one touch assessment. Secondly, I think the biggest thing that's really impacted on us is the pharmacy and the closure of pharmacies with Sainsbury's. Myself and Jane Bullard were at a meeting yesterday with our out of hours provider, saying that number one issue with the reduction of pharmacies, the closure of pharmacies within Sainsbury's across the patch, has really impacted in pharmacies and those being open to 10 o'clock at night. So I know that that's something that's been very at the forefront of lots of our thoughts and how we're going to support pharmacies, and particularly the extended hours. Yeah. So we're aware and we're cited on it, but as far as getting just in case and out of hour medications, the PPG group, which is the out of hour provider, they do prescribe. So we were hearing yesterday very clearly that request has gone up since Sainsbury's have no longer provide a pharmacy service, and I know there's some work doing around recommissioning and what further work needs to be done to make sure that gap is filled.
Thank you. That's very useful, because you've got Health and Wellbeing Board tomorrow, and the pharmacy is on that agenda, so that feeds into that very nicely. Thank you very much indeed.
No more questions. Alison?
Thank you, Chair. Just how significant is the lack of awareness on personal health budget end of life with patients? I mean, how much education do we need to give people in order so that they understand they can access?
So it would only, so there's a health funding criteria in terms of individuals having a primary health need, and not all individuals at end of life will necessarily meet that criteria. So I think that if there is something about understanding where it would be appropriate or not. And we do have a really good offer, St Luke's described last time, around the end-of-life urgent care service. So that tends to be the more proactive, urgent care end. And actually that offer works quite well because rather than a personal health budget, it can be a little bit more responsive in terms of the workforce that's there. But we do have a programme of activity from an ICB perspective looking for those individuals who are continuing healthcare funded, be that either at end of life or broader. So those individuals who have a primary health need and an eligibility for health funding. For those individuals who are at home, personal health budgets is part of our standard offer, so that conversation takes place at that stage. So once somebody's had that determination, the health professionals will then guide them in those conversations. We do a lot of work jointly, so the arrangements that we have in place locally are combined with the local authorities' direct payment support offer and arrangements as well. So I think for those individuals who need it, it's well understood. What I think there's some opportunity for us just to think about how, in the future, how we might go further with some of that in order to improve it even greater.
Okay. It's been interesting. These last two sessions have been have opened our eyes a little bit with things. So, I'd like to thank you all. It's been absolutely amazing. Yeah, I know we're going to do recommendations. Are you looking, giving me that evil eye? I know we're going to do recommendations, but I just wanted to thank the group because you've actually been amazing all three, not just for the last two sessions, but all year. So thank you very, very much, and you too that's online. So thank you so much. We are going to go to recommendations. Are there any members that feel that there is any recommendation that they'd like to put forward? I know of the last two sessions, Elliot's been scribbling away there, bless his little cotton socks. So is there anyone in particular? Natalie?
Yeah, obviously, I know Alison already spoke about shout a bit louder. But also Karen's excellent presentation on what's happening with the Estover project. I think it would be really important and useful to be thinking about it from a citywide point of view if the the findings from the Estover project are brought back to the group.
Okay, thank you. I think Elliot's probably captured that, and I think Mary's recommendation and to Councillor Penberthy was we need to consider that as well. So, Elliot, would you like to just shout out what recommendations we've got?
I've got a bit of a list of key areas we discussed. They're probably going to need a bit of discussion between us now just to sort them out. So I'll start us off. The first one from the first session was some sort of audit or survey of care homes to see whether they were equipped to deal with the full situations to prevent conveyance to ED. So I'll take one by one and we can sort of discuss whether you want to discount or take them, Chair. Yeah, of course. So it was the audit or a survey of care homes to see whether they were equipped to deal with full situations to prevent unnecessary transmissions to ED.
John?
Yeah, does that link a little bit into assuring ourselves that all the PCNs have resources directed to care homes to provide cover in emergency or even and routine care? I mean, a fall is obviously an emergency, but routine care is obviously goes on a weekly basis. Can the two be linked together, and should they be linked together?
You got any? Yeah, go on, Gary.
I think just to build on this a little bit, but we heard from Sharon and John today talking about the kind of trying to get to that more consistent response. And I wonder if it's about saying what that consistent response is and where care homes are on that journey, if that makes sense. Because I think what you're doing is you're working with all of them to say, here's a standard we want you to get to. And I guess what you'll find is you'll have some who clearly will be at standard, some might be above, but you'll also have some you're working with, and perhaps it's kind of that view that you would be helpful. I don't know.
Can I add something? I think part of the role of the 100-day challenge was to point in the direction of where the pieces of work sit. It's not within our gift to dictate what that standard should look like. I think we had an informal conversation with the LMC around their approach to that, and I think therein lies the piece of work moving forward is to what would their response be to our, I don't want to call it challenge, but what's their response to our reflection back that homes feel as though there can be a bit of a difference in the way in which that service looks. So I think if that's something that you are wanting us to look at, I think we would need to look at the LMC and look at how they feel as though they can support that piece of work, because it's not within our gift to dictate that or to. I hope that makes sense.
Thank you, Pauline. On the issue of falls, Gary, you talked about having a wider look at the committee looking more widely at falls in general and how that prevents various things and leads on to other things. Would that recommendation not fit better in a separate session about falls?
I think we're kind of talking about two things now. In terms of falls, I think that's a future agenda item conversation.
I don't disagree. What I was suggesting was that particular recommendation and discussion perhaps should be recommended to go forward into a wider discussion on falls rather than specifically on.
Are you suggesting add to the work programme some sort of discussion on falls and the numbers conveyed to ED?
Some of the recommendations from here are into that rather than.
Sorry, I've left my mic on. I think for me, I describe falls as being a subject in its entire right, rather than something separate. Yeah.
And we do, so Gary, as you said, there's a whole separate work programme around that, so it's something that we recognise as a challenge for the system, and there's a particular care homes component within that, and a focused programme of activity. So yeah, if that at a point in time wanted to come through, then we could pick that up.
One thing that just crossed my mind is that the fact that we have more and more pharmacies closing down, the focal point of the people that are in care are care homes or hospice as a final stage of their life. And it just crossed my mind, wouldn't it be possible to have, because of the specialized need of those individuals, to have some sort of pharmacy available in those institutions, because they already have a professional nurses that are operating there, and those places are open 24/7.
Stefan,
it's just a suggestion.
Stefan, can I just stop you there? We were just talking about that first recommendation. We've not gone on to anything else. We were just talking about that.
Oh, sorry.
That's okay.
So through you, Chair, take the first recommendation as add falls as an agenda item to a future work programme. I think we'll leave that one at that, if that's happy for the first one.
And if I might come back, because I think, Sean, what you've helpfully done is you've described clearly there are some things out of the gift of the research and you need to go back to the LMC. I think what the work you're doing is trying to describe a standard, isn't it, about what you would like to see, and therefore you'll have a view about where people are on that standard, and there'll be some parts of that you'll need LMC, and there'll be other parts of that are kind of more within the local system gift. So I think it's probably just teasing that out and saying, here's our aspiration for a consistent response, and here's where we see our position in Plymouth. And I think that probably is something that could form part of the recommendation, but we have to acknowledge there are some things that no one in this room can just make them happen. That's a process of engagement with other bodies and things like
that.
I'll go on to number 2. Thanks, Chair. So the second one I have down is to understand how many people who had died in hospital would have preferred a death at home. obviously through family members. This was again from the first session, and it was suggested some sort of collection of figures in the hospital survey. Might need some more talk on that.
So I think, and this comes back to our data capture piece and making sure, particularly for the demand and capacity analysis, understanding people that we're identifying people's preference and that we're capturing it and then measuring our delivery against it. So that's one of the big priorities that we have in terms of how we take that forward. So we ought to be in a better place in terms of coming back to give an update in 6 months' time. That could be one of the things that we can make sure we can cover.
Any feedback from the other members? Yeah, you all agree that you want that as a recommendation? Yeah. Yeah. Seconder? Natalie.
I'll just clarify on that one, Chair. It sounds like there's two parts to that. One is to recommend that NHS Devon captures people's preferred death location in support of their improvement plan. And the second part would be to add the update to a future agenda item.
Natalie's going to second. We've proposed, they've agreed. Natalie's going to second.
Moving on to number 3, this one may be discounted now, but I'll read it out anyway. The income stream for St Luke's was highlighted as maybe not secure, but then I think you came back in your later presentation and said that there was more of a consistent lineup of funding. I wondered if you could clarify that briefly.
Sure. So I think this was last time, wasn't we had, as you say, the conversation around that long-term funding, and I think the clarification was more around the ICB's commitment in terms of the grant payment that comes through is consistent and multi-year that enables planning. I think Trish, look at you, because I know obviously you raised this point, it was as much around where there's other pressures, so like the pay award that was agreed for NHS staff, that creates additional cost pressures that then become difficult to plan for, isn't it? So it's more that those additional pressures over and above that's difficult. But I think in terms of the specific ask and this recommendation, we covered that off in terms of the agreement that's in place.
I agree, Chris. It's more, as all organisations will, we await the medical pay award, but yeah, and obviously as ourselves with sort of 24% statutory funding, it just leaves an awful lot that the good people of the communities we serve fundraise for us. So it's just bringing that to the table, but recognising that all hospices are in that space, and we're certainly yeah, we will do all that we can to try and make sure that we do meet the needs of commissioned services and try and get that statutory funding, but I don't think there is an ask at this table.
Okay, thank you. I'll move on to number 4 if that's all right, Chair. This one I'm not sure we're going to get a straightforward answer on because it's difficult to answer. It's an issue raised with needing to establish a point at when extending life care becomes making it comfortable or palliative care. So some sort of recommendation that that's something that really needs to be worked on or highlighted, or where we could go with that, Chair. Yeah, so just to repeat that, there are issues with determining when a patient goes from extending life care into end of life care, essentially, where that fine line is. How do you define that? And I think it was felt by the committee at the first session it would make it more straightforward if you could easily go, right, this is the point, you move on. Obviously, that's not straightforward.
Therein lies an awful lot of decision making, joint decision making with families and patients. All of the amazing clinical work that goes on is navigating that really tricky road as to where somebody sees, actually, I would like to accept this as potentially it might give me a little bit better quality life, or whether actually I want to use this time to enjoy the time I have and actually die and let and let nature take its course in some way or another. So it's the constant things that weigh on all of our minds about how we work and how our colleagues work with patients.
I think just to add, sorry, you talked last time about the gold standards framework. An element of that is around prognostic indicators. So looking at the different diseases and the likely trajectory. And again, the training and the awareness raising around what people's wishes are and identifying end of life care. And I think it has to be done on an individual basis. But our role is to make sure that anyone working in and around end of life care is skilled and confident to have conversations around identification. And I think the work we've talked about should touch on that.
I would echo that, and I think whilst there's sometimes a desire, and I think what we've learned through these sessions, which have been fantastic, is this is not a precise and exact science. There's an art form to some of what happens, and it's a really complicated part of our system. Sometimes we have a desire, don't we, to really box and process, but I'm not sure there's a recommendation here that you could deliver on, and I think what we've learned, certainly been helpful for me, is just how fluid and individual that process needs to be for people. So I'm not sure, Elliot, for me, that there's something we could describe.
That's fine, thank you. It was a point worth raising. I'll move on to the next one, which was identify delays to sort of tests and diagnosis, therefore leading to people maybe dying prematurely in hospital before they're given the option to move out. So some recommendation around the need to increase capacity for sort of diagnosis times and tests. And obviously we mentioned how the CDC would come into play. So it could be monitoring of performance of the CDC and whether that speeds things up. But over to you to discuss, Chair.
Sorry. So I do believe that there has got to be some recommendation because we need to stop this. Sometimes there's stuff happening that shouldn't be happening. And so I don't know how we're going to put it in a recommendation, but we do need to put it into a recommendation.
So there's kind of two components to that. So absolutely hear that. I think so first of all, there's the demand, coming back to the demand and capacity modelling, so understanding the need that we have. But certainly if that's one of the recommendations you want to make, and I understand why, that's something we can build into our update to you, is actually what's some of the activity that we're seeing around diagnostics and what's that telling us, and where are we seeing improvements or not. If that's helpful, perhaps that's the best way that we can bring that in.
Chair,
Mary.
I feel on your behalf, and I know where you're coming from for this, but I think one of the recommendations needs to be that people going into hospital towards the end of life need to be given the opportunity to decide what their next step is more clearly, because I think there are people going in, and we accept that then don't get that opportunity, then stay in Derriford, and they don't need to. They could have gone to either St Luke's or down to Mount Gold or wherever, or go home. They didn't need to stay in. And I think that needs to be a clearer pathway, that somebody within the hospital, once you have done those diagnostic tests, makes that decision speedily, rather than delaying it. And I think so we need to just encompass that in the recommendation, I think.
If I might, Chair, I think we've talked a bit today about trying to invite people back, and I think in that invitation back, if something was included around the metrics and measures around access to tests, I think this starts to demonstrate either the improvement, but you'll be updating people around the progress you're making in terms of time tests, which I know is a big issue and a big subject within UHB anyway, so will be something we focus. I think that might be a way of trying to capture this.
Yeah, that's fine. Something to the effect then of the committee stresses the importance or urges the importance of testing times and diagnosis, and that those tests are times and delays are reported to a future session.
Sorry, all members agree? Seconder? Take a pick.
Yeah, I still think there's that bit about once that a decision has been made, that it is timely and it is relayed to that person and the family so that they can then decide. I think it's not just the tests, it's then once that's been done, there is a timely way that the outcomes are given to the family so that a decision then can be made as to what the next step is. And that to me, it all comes into this part of that good death, if there's such a thing, you know, that we should be looking at. So I think it's a two-part thing, Elliot. I think it isn't just the tests. It's then how that decision is communicated appropriately so that further decisions can be made as to what the next step is. I'm not too sure how we compass that, but that's what it is. It's both.
I think through you, Chair, we can leave formal wording because there'll need to be careful consideration to outside, as long as the committee, as they just have, agree on the fundamental principle of the content. So that's done. Thank you.
So part of our work has been around some of that decision making when people present the ED, and also with our hospital palliative care team. It is around that decision making, and it isn't always completely clear. And I think it goes back to the conversation earlier about, will this one more intervention work? You know, is this additional, you know, course of antibiotics the right thing for you? And very often that isn't clear whether that will or won't work, and that will be around negotiation and talking with the patient and talking with family. So I think there is something about the nuances around that decision making that make it quite difficult unless it's something that's really clear that person is end of life. It very often is not easily labelled, and that can be really challenging for some of our medic colleagues even in the trust. They're amazing.
I'll challenge you on that. I'll challenge you on that one, definitely, but it's not for this meeting. But certainly, I think sometimes it is very clear cut, but people don't act. Whether it's probably for good intentions, don't get me wrong, but they don't act. So I think, yeah, you and I have a conversation in a minute.
Will?
I just think Mary's words there, I think was perhaps catching the gist of what may have come out from the last. It was quite heavy going that first session. I think, you know, that kind of, so people can sort of think about that sooner and maybe plan sooner. You know, that was perhaps that's what that's what I understood from when we had that discussion in the first, or that discussion was going on in the first session, is what Mary sort of said there. It's about people. So, you know, the idea, the concept of that being at end of life is you know, discussed with the patient and their family, so they can make choices that perhaps might be better for them. So that I think is what, you know, that's the thing I understood from the discussion, but you know.
That's good. Yeah, and I agree. But sometimes you can't. That decision is taken away from you because those tests haven't been done, and then it's too late to make any decision to where that person can go. So, so that's another issue, if I'm being totally honest.
We'll finish that, working that one out, Chair. I'll move on to the next one, which is hopefully easier to summarise. There was a need around getting the communication of St Luke's services right, and it was put that it's the hospice coming to you rather than you going to the hospice. So it's quite commonly thought of as someone would go in, but actually there's the huge community service. So something about working with St Luke's to promote that message and reinforce that.
Agree with that. Any members got any thoughts? Alison? No. Oh no.
Agree.
Yeah. Okay. So we agree, all members agree with that recommendation? Yeah, seconder, Alistair?
Lovely, thank you, Chair. Moving on. So the next one I have revolves around the TEP form, and basically I think it could be wider than the TEP form. It's the need to involve, or at least trigger, the conversation of, would you like your family involved in sort of your decision planning, something around that.
I agree with this one as a recommendation. I don't know if members have got any opinion on that, or any of our partners there.
I think, you know, and we've described a little bit more today, haven't we, around some of the approach that we've got and how embedding that within the shared care record, but also the training bit. But yeah, absolutely, that's something we can think about how we can give some more assurance around that moving forward.
Okay, so do all members agree on that recommendation? Yeah, seconder? John? John?
Thank you. I think that'll be interesting to bring back as well in the update in 6 months' time of how have things progressed on that front. So the next one I have is the housing recommendation. Mary, I might want to defer to you on the words you used earlier. Something to the effect of having the appropriate homes for those with higher needs of accessibility and quality.
I think it's a case of very quickly having that conversation with Councillor Penberthy and with Matt Garrett to make sure that that's in that housing needs assessment that's going to be published fairly soon, isn't it, Gary, from what I'm understanding?
And housing needs assessment will be, and I think this was about the project, Karen, that you were talking around. And for me, there was something here about making that connection, about getting feedback from you about what you see and what you experience and what you think that the benefit could be if that situation was different on those individuals, and tying that information back in to the housing thing, I think for me would be the kind of, feels like a nice way to try and connect it to get your experiences. The housing needs assessment is a process and it will keep being updated, but that connection between what you're seeing in your pilot, which is a targeted bit of work around housing standards and what you feel, could improve things to make sure that message gets really loudly and clearly into the housing standards work would be quite maybe the way to do it, Mary?
Because if you've got to use disabled facilities grant to alter somewhere, that soon gets eaten up because we only get a certain amount of dosh, don't we, for that? So whereas if you had some other homes that people could have had that choice from moving from their 2-bedroom place in Wyberth Gardens to a bungalow, that might have saved a whole lot of adaptations that were needed and time that takes. So I think that's something that this will feed into, and I think that I'm sure that Councillor Penberthy is aware of it, but I think we just need to echo that.
So that would be a recommendation to the cabinet member on that front. Propose a seconder, please.
So do all members agree? Yeah, seconder? Yeah, yes. So we can agree, so we agree.
Thank you, Chair. Now just onto the recommendations actually contained within your reports. So that was for us to consider the current provision and performance, which we've done today. That the Health and Adult Social Care Overview and Scrutiny Committee supports the improvement and development approach being undertaken within the city and supports partners with its delivery. Over to discussion.
It was a recommendation that we revisited this in 6 months' time. I had an update.
Yeah, apologies. I thought I'd cover that. The last two on the list were that NHS Devon and partners return in 6 months' time to provide an update, and that the Estover project is brought back.
Well,
could you reference the palliative care ambitions framework actually specifically? Because from what you've been saying, these are all things that you're working towards. I know that lots of different elements and parts of the overall health system and partners, and but this is what you're working towards, and I think that perhaps specifically be referenced, because this is drawing together all the things we've been listening about and learning about into one sort of strategy, or what, quick, whether that's the right word, but going forward.
Yeah, thank you, Chair. Just to clarify, we'll bring that back as part of the 6-month update, palliative care framework. Yeah, to track the progress.
So, you've heard the 3 recommendations that Elliot's just put to you. Do all members agree? Yeah. Seconder? Take your pick.
So we've just got the 2 left that are actually on the actual report, Chair, which is that we support the improvement and development approach being undertaken, and that we help raise awareness of deaf literacy and promote its importance. We agreed on that.
Yes. Mary?
I think we'd agreed that I'll discuss with Ruth about Dying Matters Week, that's the 6th of May to the 12th of May, that we actively do something about that. So I'll have that conversation the next time I meet up with her about getting something organised for that. I think that's really important. So there may well be some coming back to some of the people here today to say, you know, can you have, we get some headlines, and certainly St Luke's, obviously that Dying Matters, we can bring them in as well. So Ruth and the team, public health team, will have some conversations. Okay.
Thank you, Mary. Okay, you got them all? Yeah? Okay. Thank you all very, very much. Once again, it's been a pleasure working with you. I think this is our last meeting, isn't it? Yeah, it's our last meeting. I've not finished with you. I'm just finished. I'm not finished with you. But it's been lovely working with you, and who knows who's going to be chair next time? We don't know, and hopefully they'll just carry on with the work recommendations that we're putting forward anyway. So hopefully, but like I said, nice working with you, and I'll take care, and hopefully see you all soon. Thank you. Right, now we've got tracking decisions. Elliot.
Thank you, Chair. I'm not going to go into too much depth, but members, please ask questions on ones that you need to. You'll note that there's 5 now complete and 7 in progress. My aim is to have all but probably one of those completely wrapped up before we go into pre-election or during pre-election. So I'll circulate the responses to those to committee members. There's a big piece of work here to do with the quarterly performance and finance report. Lots of the further figures and requests that we put through have come back. They've been compiled by Rob Sowden, so it would be my recommendation in the work programme that we have that quarterly report, because there's a lot to sort of consider and review next year. There's responses to the pharmacy questions we had last time within the pack, and that's about all that I'd like to highlight, Chair, but welcome any questions.
Angela.
Very, very brief question. I was very grateful for the response in each of them, because, you know, a lot of them seem to be a little bit in the air. So, you know, I look forward to reading what you're sending. But then I just paused a bit, you know, the one where we make it's complete, that we recommend going to the Youth Parliament. But how would one find if that recommendation had been effective? You know, we just do our bit and say it would be a good idea if, but is there any way of further down the line finding out if anything has happened?
Yeah, thank you for your question. Are you talking in relation to recommendation 10 that the committee recommends The Plymouth Education Board encourages Youth Parliament. Yeah, so that would be our way of following that up, would be to engage with Youth Parliament either by reaching out through yourselves or the chair, or reviewing it and taking it back to a future agenda item as a follow-up to see how has this actually progressed. The action itself has been completed, but I take your point, how effective was it? That's why we review these, and we should then go work programme.
Actually, yeah, I'll just come back on it. Obviously, all members are able to attend Youth Parliament. The elections are imminent, and all councillors will be invited to go to the the final count, so to speak, and the and talk to the young people that are involved in it. And I'll be very interested, and I will be following up as a shadow cabinet member, and I know others within it, to find out and make sure that actually our schools are involved and that all of them are engaged. I know Jenny Way, who's in charge of it, is doing a great job trying to get out there to the schools to make sure that they are, they know about the elections, taking ballot boxes, etc. So that we can make sure that all schools are engaged. And from an education scrutiny point of view, that has gone back as well, to be pushing for schools to be making sure that they engage with the Youth Parliament process. So I'm sure. Whenever I can. Without winning, I'm just in a little world of my own at the minute. Okay.
So, sorry, through you, Chair, I'll just say that I will go through those, as this is the last meeting now, chase down all the final responses and circulate them as soon as I can. Obviously, there's a few in progress here, and we want to get them wrapped up before we start again.
Yeah, there's quite a few that are part complete, isn't there?
There are 7 part complete, Chair. What I will say on that is I've marked them part complete if the report is fully there, but we just haven't seen it yet. So for the performance finance report, if we consider that at the first meeting of the new municipal year, that will take about 4 of them to complete.
Okay. Can I just ask, Elliot, are they just part complete because we're not getting any responses from the people that we should be getting responses from?
No, since you're helpful chasing, Chair, I get quite swift responses.
Okay. Mary.
Just to say, the one about vaping, etc., is part complete simply because we're waiting for the next lot of consultation results to come out from government. So that's why that's on hold, because it's not much point us putting something together and then government come out with something different, or so that's why that's partly complete. And what else was there? Was that the defibrillators? And certainly we're getting reports slowly but surely that defibrillators are being installed, and certainly the one at the Guildhall will be installed when it's finished being redone. No, exactly. At the moment it's behind all the barriers anyway. So that's part of the reason that. But it's the education board that need to report back, isn't it, that they have done something. So I think if we can find out who on the cabinet represents us on the education board, we could perhaps ask them. I presume Sally or Jemima, I don't know which one, it's probably Sally, but I think we need to sort of chivvy them and ask them, and I'm quite happy to do that.
Thank you, Mary. Okay. Yeah, I know. You're giving it to me today. Work programme. Elliot.
Thank you, Chair. So I'm mindful that this is the last meeting, and it's your choice, but I wouldn't want to preload a meeting for a future committee. What I would say is it's really important to consider the quarterly performance, finance and risk reports, sort of set us out for the year on what is the position now, what are the risks, and how are we performing, and also a lot of those actions are relating to that. there are, as you can see, a load of future items there, and members feel free to suggest ones that you think are important, but I would be cautious about preloading when there's quite a lot of time before our next meeting.
Members got any thoughts? No? Okay, well, we'll just go with the ones that we've got, and then well, that's
Right,
if it is
yeah.
us. I don't know who it's going to be.
Yeah.
Hopefully it will be.
Leave that to closer to the AGM then. Chair.
Sorry?
We'll leave it till closer to the AGM.
Yeah, I
when
think so,
positions are
because I
confirmed.
think it would be nice if we could keep the same committee, because I think then that gives it clarity, and when you start messing people around, it loses it all, I think, but hey, who knows? Okay, is that it? Can I just thank all members, because it has been a really good year, I think, for your input, because it has been valuable, and hopefully that's if you want to sit on it. Maybe we'll see you again here next year. I'd like to thank you, Mary, for attending every meeting. It's been lovely having you for your input, because it is very valuable. Gary and Elliot, and thank you, because you have been outstanding. And I know sometimes, Elliot, we have a little bit of a banter, but I do appreciate everything that you've done throughout the year. Thank you. Thank you all very, very much. And thank you, Chris.